Thank you, everyone, for joining us today. We are kicking off our second webinar with COA, and we're excited to have Dr. Allison May with us here, who is a urologic oncologist at UVA Health. And we're excited to talk about sarcomatoid features in renal cell carcinoma and also addressing sarcomatoid features in Chromophobe RCC as well, too. So welcome, Dr. May, and we're grateful to have you join us for the session today.
Thank you so much. I'm very excited to be here.
So to kick us off, I was wondering if you can introduce yourself as well as what your role is in treating kidney cancer. And then if you may also be able to share with us a little bit about your lab and your interest and experience in sarcomatoid RCC specifically.
Definitely. So as you said, I'm a urologic oncologist at University of Virginia. So that means I treat patients clinically and surgically that have genitourinary malignancies. So the majority of patients I see, my specialty is kidney cancer. So I'd say about 80% of the patients that I see have kidney cancer. Typically, if they're seeing me, they usually have a tumor that's confined to the kidney. And that's why we're talking about potential surgery. I also see a lot of patients that we're just watching their tumors. A lot of kidney cancer we don't have to treat immediately. And then I do see some patients as well that have disease that has spread, metastasized. Sometimes they still could benefit from surgery, or I'm working closely with colleagues in medical oncology that would treat them with systemic therapies. So that's my clinical practice. And then I also run a research lab studying kidney cancer. And we're really focused on trying to understand how tumors develop into this aggressive kind of phenotype. So how do tumors become localized where they're confined to the kidney and become more aggressive and metastatic? And we think that if we can really understand the biology of how this happens, then we can develop therapies to block that or prevent it. And we're particularly interested in how tumor cells interact with the immune microenvironment and how that can lead to tumor regression or progression. And we've been studying sarcomatoid. That's a main focus in our lab because this is one of the most aggressive types of kidney cancer and also has some interesting immune features that we'll probably touch on later. But that's been a large area of focus in our lab. So I do see patients that have sarcomatoid, and then our lab is really focused on studying it as well.
And that's a great segue to our next question, which I was wondering if you can explain what sarcomatoid features are, if it's a specific subtype of kidney cancer or if it's a specific presentation, and if you can explain to our viewers kind of how it's different from other presentations of kidney cancer.
Definitely. So sarcomatoid is essentially it's something that we see histologically. So when we look at tumors under the microscope, we see changes that are called sarcomatoid changes. And I can actually bring up a slide here to show you what this looks like, and that might be more clear here. So I will see if I can share my screen. So this is since we're kind of focused here on chromophobe kidney cancer, this is just a picture of what chromophobe with sarcomatoid changes looks like. So you can see here these patches of chromophobe kidney cancer. So the cells are kind of pale or eosinophilic, which means they look pink. They have these really prominent borders. And what can happen in chromophobe or any other type of kidney cancer is these cells can undergo this transformation where they look like this. They're more spindle-shaped. They have a lot of what's called pleomorphism and atypia, which just means the cells don't look like each other. They're very irregular. The nuclei, the dark spots that you see in the cells, are different shapes. And when we see those findings, that's called sarcomatoid disease. And so often in a tumor, you'll see patches of chromophobe or whatever the main kidney cancer type is, and patches of sarcomatoid. And it's thought that these chromophobe or other cells actually transform into sarcomatoid cells. And when we see this, we know that those tumors tend to be very aggressive. So any degree of sarcomatoid within the tumor, we usually designate that tumor as having sarcomatoid dedifferentiation. And we just know that those tumors can be very aggressive, high rates of metastasis.
I appreciate the image. I know for me, as I was first learning about kidney cancer and sarcomatoid features, it was really helpful to visually seen. I had been explained to before that cells that are more aggressive can look a little bit more irregular because they might be copying themselves faster and not doing as good of a job. And I think what that image really shows is it helps show that visually, where you see they just look very different from the rest of the tumor cells. So I appreciate the image and the visualization there.
Definitely. I think sometimes it can be a lot easier. A picture can can speak 1,000 words.
Absolutely. So, how do you talk to patients about sarcomatoid features? Is it something that you typically talk to them about in clinic if you notice it in their pathology report?
Yeah, so I definitely explain that, like I said, sarcomatoid, when we see it in a tumor, we know that these tumors are likely to behave more aggressively. It can also mean that they may be more responsive to different types of therapies. But it's important to know, and it's not a separate subtype. So a lot of people think sarcomatoid disease is its own classification. It's not. It can occur in any type of tumor. So it's really more of a biologic process that just shows that these cells are undergoing a transformation that makes them more aggressive.
That's helpful to know, especially as I know patients might see certain studies that are reporting out the results of a trial or response to treatment. And being able to see sarcomatoid listed there is often listed in some of those reports, and helping to put into context that that is kind of a presentation of whatever type of kidney cancer that they're reporting there. Do you know if it's seen more frequently in certain subtypes versus other ones, or is it kind of similar all across the board?
So that's an interesting question. We know that in kidney cancer as a whole, about 5 to 10% of tumors will show some degree of sarcomatoid change. The most common type of kidney cancer is clear cell renal cell carcinoma. That's in about 75 to 80% of kidney tumors. And within clear cell, about 5 to 8% of these tumors develop sarcomatoid changes based on, large studies we have. Then there's other subtypes like chromophobe, which is only present in maybe 5 to 10% of kidney tumors. And within chromophobe, about 8% of those tumors have sarcomatoid changes. So if you're looking at kidney cancer as a whole, we're going to see a lot more clear cell patients with sarcomatoid because it's much more prevalent. But people do think, or there's some data to suggest that chromophobe, since it has a higher proportion of tumors that have sarcomatoid disease, that these tumors may be more predisposed to developing sarcomatoid changes. But I think, it's also a very kind of nuanced thing to think about. So sarcomatoid tumors are usually pretty aggressive, meaning they're often very large tumors. So if you look at just advanced tumors, meaning locally invasive or metastatic tumors, about 20% at least of those tumors will have some sort of sarcomatoid change. And so one of the other important things to think about as we think about sarcomatoid disease is that it may be understudied. It may be more prevalent than we know. So if you can imagine like these large tumors that often they are, it's not really feasible to look at the entire tumor under the microscope. So what the pathologist will do is take little blocks from different areas of the tumor and look at those. And sarcomatoid often is just seen as like small little patches. It can even just be like a few foci within the tumor. So if you're not seeing the whole tumor, there's certainly a chance that we're missing sarcomatoid disease here and there. So I think, long story short is basically all tumor types in kidney cancer can undergo sarcomatoid changes. So we see it in clear cell, chromophobe, papillary, pretty much every subtype. And which one occurs more is probably about the same in most of the tumors, but certainly it can happen in chromophobe.
That's very helpful context to know, especially as patients might try to understand their own pathology a little bit better and their own disease. Do you know, for patients that may not have had sarcomatoid features mentioned to them, do you know where they can typically go to look to find out if their tumor might have sarcomatoid features? Is that always listed in their pathology report, or how would they find out if it was a characteristic of their tumor?
Yeah, so it should be listed in the pathology report. So nowadays, now as we're learning more about the importance of sarcomatoid, it's pretty standard that the pathology report will say, it'll usually have a line that says sarcomatoid and or rhabdoid changes. And so rhabdoid is another histologic change that can be seen in these tumors. It's often seen along with sarcomatoid changes. And it has very similar features to sarcomatoid clinically as well as molecularly. And so these are kind of usually lumped into the same pile. So if you see sarcomatoid or rhabdoid, that typically means the same thing or very similar at least. And so what you'll see in your pathology report is you'll see a line that says sarcomatoid and or rhabdoid differentiation. And usually it'll say present or not present. And then often the pathologist will also list the percentage of what's seen. So, 20% of the tumor had sarcomatoid changes.
And I know you mentioned that for the large tumors, they can't sample kind of every section of those tumors. So, do you know how the percentage, does it change anything about the treatment or the disease course based on the percentage? Or how do they calculate that percentage if they can't sample kind of the whole tumor?
Yeah, so it's usually calculated based on what they did sample, kind of assuming that what they took is hopefully pretty representative of the whole tumor. And so let's say all the slides they looked at, they saw roughly 5% had sarcomatoid changes, they'll list it as 5%. If you see something like focal sarcomatoid changes, that usually means just like very small areas, so like less than 5%. And it is important because the proportion of sarcomatoid disease in a tumor has been shown to be related to clinical prognosis. So the more sarcomatoid disease, typically the more aggressive the tumor is and the higher risk of metastasis. When you get to at least like 25 or 30% sarcomatoid disease, there's going to be a very high risk of metastatic disease or, recurrence. A lot of times these patients, if you're getting a pathology report, it's often because you had the kidney tumor removed. And so the percentage of sarcomatoid that you see can definitely correlate with the risk of having disease down the road.
And do we know what causes sarcomatoid features in these tumors or what causes I'm thinking of your image again and talking about how
Mhm.
those regular kind of tumor cells might transform into sarcomatoid features. Do we know what causes that process?
So this is the question really, and this is what my lab is really actively trying to study better. So the short answer is not completely. We know, so cancer in general is thought to kind of occur through mutations to the DNA. And so a lot of the prior work that's been done in sarcomatoid disease is looking at whether we can identify specific gene mutations that lead to sarcomatoid disease. And what we found is that in tumors that have sarcomatoid, there are certain mutations that are more likely within those tumors. So, for example, TP53 is a gene that is a tumor suppressor gene. So its role is kind of to keep cells functioning in a normal way. And if it gets mutated, then cells can start replicating out of control and kind of go haywire, and all sorts of different signaling can start happening. And so we know that in tumors that have sarcomatoid changes, we see higher rates of TP53 mutations. There's other mutations as well, BAP1, NF2, there's a lot of them. But what's interesting is in the epithelial area of the tumor. So by epithelial, I mean clear cell or chromophobe, the main tumor type, compared to the sarcomatoid area, we don't see differences in mutations. So those two areas typically look the same as each other. So essentially, what that says is there's genetic mutations that may predispose a tumor to having more risk of developing sarcomatoid disease, but that may not be responsible for the actual sarcomatoid change itself. And so a lot of work has been done to try to understand, what else could be responsible. Um, There's a biologic process called the epithelial to mesenchymal transition, or EMT. And essentially what this is a process that occurs in healthy cells. So it's an important part of biology. It is important in things like embryogenesis and wound healing, but it can also be hijacked in cancer. And so essentially what it is you have these epithelial cells that are, they have epithelial features, meaning they have adhesions to each other. So the cells nearby, they communicate with each other, and they're really focused on proliferating, so kind of growing and replicating. But they can undergo this transformation where they lose those epithelial features and they gain mesenchymal features. Mesenchymal features are things where the cells begin to look more spindle-shaped, like you saw in the sarcomatoid areas. And instead of, they lose those features where they're not attached to the cells nearby and they're not communicating in the same way. And instead of focusing on replicating, they're focused on invading. So they can invade into the bloodstream and they can become metastatic. And so this is called a epithelial-mesenchymal transition, and we think that this is how sarcomatoid develops within the tumor. So the chromophobe areas or clear cell are very epithelial. The sarcomatoid areas are very mesenchymal. And we think that it's this transition that is leading to the sarcomatoid changes. And so it may be that tumors with certain genetic mutations are kind of predisposed to developing EMT, and then EMT leads to sarcomatoid. And what causes EMT in these tumors is what we don't know for sure. EMT in general can be caused by a lot of things. So hypoxia, meaning the cells don't get as much oxygen. So a lot of times as tumors grow large, they don't have enough blood vessels to bring the oxygen in. And so those areas can get hypoxic, and that can lead to EMT. Cytokines, which are things that are released by cells, particularly immune cells, can lead to EMT, and treatment with different drugs can. And so we don't know exactly what it is in these tumors. It could be all of the above. It could be, certain unique things that are being triggered. But that's something that my lab and many others are really trying to study to understand. And potentially, if we could figure out, what's causing it, then hopefully we could, prevent that.
It's very interesting, and I think it's helpful that you described both of them, because I know TP53 is a mutation that's more commonly seen in chromophobe. It's one of the most common ones, along with P10. And so helpful to know that basically, if I understood your explanation correctly, that the mutation in those tumors are happening in both types of cells. So if you have that mutation, it doesn't mean you're going to have sarcomatoid features. It just means that of the tumors that have the sarcomatoid features, it might be more common for them to have that mutation. Is that correct?
Exactly. So, and in chromophobe as well as clear cell, TP53 is one that is definitely seen more in tumors with sarcomatoid. But like you said, it doesn't mean that that if you have a TP53 mutation, you'll get sarcomatoid. But I do think, and this is just, my thought in studying these tumors, there's probably a higher risk, or like these tumors are somehow wired in a way that means they're more susceptible to developing sarcomatoid-like changes.
And did I see that you just might have received an award from the Cancer Research Institute? I saw a tweet recently of that. Is that studying this process here, the EMT, and kind of trying to figure out what the mechanism is that kind of causes that
Yeah.
shift?
So what we've done previously is really tried to study this transformation, this EMT transformation in kidney cancer. And what we found, so I should say EMT, I explained like the epithelial to mesenchymal kind of change, but it's not just a binary switch. It's not like you have epithelial and it suddenly switches to mesenchymal. It's this gradual kind of continuum. And that's well studied in other biologic processes, but we just don't know a ton about it in cancer, specifically kidney cancer. And so some of our prior work was trying to study this continuum, and we found that there's this intermediate state that we can detect, and we were looking specifically in clear cell sarcomatoid. But essentially, you have clear cells that are very epithelial, you have sarcomatoid cells that are very mesenchymal, and in between we could find these cells that looked like clear cell but had sort of this hybrid EMT state where they had both epithelial and mesenchymal features, and they also had features suggesting they're along this transition towards sarcomatoid. And interestingly, those cells had high rates of inflammatory kind of features, so things that would bring in immune infiltrate. And so what we're trying to do now, and we were very fortunate and excited to receive the support from the Cancer Research Institute, is studying how EMT and the process of EMT itself may shape the immune properties of the tumors. And our hypothesis is that this early EMT state, so where you go from epithelial to kind of this hybrid state, that may induce features that are inflammatory and bring in immune infiltrate. But what we see as you move on to a fully mesenchymal state or sarcomatoid is actually those areas tend to be more immunosuppressive and they lack the same immune infiltrate. And so we think that there may be a continuum of immune properties along this EMT continuum. And so we're very interested to study that further and see if that can help us understand immune properties and immunotherapy response in these tumors.
That's fascinating in the context that sarcomatoid features have been more recently associated as possibly an emerging biomarker with response to immunotherapy. And is your hypothesis kind of along the lines of it might have something to do with that kind of in-between state where it's recruiting those immune cells? Or do you know the emerging biomarkers that are currently being studied with response to immunotherapy? Can you explain that for some folks that might be listening of kind of how they might have found the signal for a possible biomarker with sarcomatoid features and how it impacts the response to treatment in those?
Definitely. So sarcomatoid, and one of the reasons that we were so interested in studying it is because it is more responsive to immunotherapy. And we know this now from some of the large clinical trials, specifically a lot of these trials that have looked at immune checkpoint inhibitors compared to tyrosine kinase inhibitors, which is one of the other mainstays of treatment in kidney cancer. And what they found by doing some analyses, like sub-analyses of just the patients that had sarcomatoid disease within those trials, is they found that within patients with sarcomatoid disease, those patients far and away respond much better to immune checkpoint inhibitors than to TKIs. Even in patients, so when you compare sarcomatoid patients to patients in the entire cohort, so without sarcomatoid disease, in some of these trials, the patients with sarcomatoid disease, even though it's so aggressive, responded at higher rates to immunotherapy than did, the whole cohort. And so there's something about sarcomatoid disease that makes these tumors more immune responsive. And that's really interesting because EMT as a whole, when you study it in other disease states, is typically associated with immunosuppression and would not typically be thought to be immune responsive. And so there's something going on there, and that's, kind of what prompted us to start studying this. And so we really think that it may be something within this transformation process that is leading to immune infiltrate. In clear cell tumors, you do see really high immune infiltrate in tumors that have sarcomatoid disease. But interestingly, what our work has shown is it's not necessarily in the sarcomatoid areas themselves, but in these sort of intermediate areas where you're really seeing a lot of immune infiltrate. And we think understanding this dynamic process may help us really understand which tumors are going to respond and how the sarcomatoid process is interacting with immune cells to create these changes.
It's very interesting in also understanding that chromophobe is less likely to respond to immunotherapy than most of the other subtypes, but there's been some signal from a recent retrospective review, for example, from MD Anderson, that showed of the patients that responded to a pure immunotherapy combo, the only responders had sarcomatoid features. And so I'm curious if you think that kind of exploring those mechanisms might help explain why some chromophobe tumors might have some response. And if you have any hypotheses as to why chromophobe, even though they might respond more if they have sarcomatoid features, they still don't see quite the same level of responses as clear cell. Is that been studied at all to figure out what the differences are in there? Or is that an area that you're looking to explore further?
Definitely. So, chromophobe tumors, it is pretty well known now that they just don't have the same immune infiltrate, and that's probably why they're not typically very responsive to immunotherapy. The tumor cells themselves just don't seem to have the characteristics that draw in immune cells. Um, but as you mentioned, there is some retrospective data showing that chromophobe tumors that have sarcomatoid changes may respond at higher rates anyway than other chromophobe tumors to immunotherapy. And I am not aware of any data that has actually studied within chromophobe tumors and sarcomatoid areas, whether there's changes in immune infiltrate. We do know that in chromophobe tumors, similarly to clear cell and other tumors, they tend to show increased PD-L1 expression in sarcomatoid areas. PD-L1 is one of the checkpoints that a lot of these drugs are targeted against. And so that may explain some of where when you kind of take the brakes off of that checkpoint, the tumors can respond, but they also need that immune infiltrate, we think anyway, to have the immunotherapy response. And so I don't think we have enough research yet. Chromophobe itself is less common, as only 5 to 10% of patients. And then within that, only maybe 8% that actually have sarcomatoid disease. So it's very rare, and that makes it hard to study. And I think requires multi-institution collaborations to really get the numbers large enough to study these tumors. But I think it's an important and interesting question that we need to understand. And I know my lab is very interested in understanding this. We see a lot of differences in clear cell and chromophobe, where they'll even behave kind of opposite based on what genes you're manipulating. And so understanding how that sarcomatoid transformation is either very similar or different in chromophobe, I think could also help us understand sarcomatoid as a whole. And my hypothesis would be that maybe this EMT signaling as it arises in chromophobe tumors could also lead to some immune infiltrates like we see in clear cell. And that may, this is just a hypothesis, but that may be why chromophobe tumors with sarcomatoid changes respond at least at higher rates to immunotherapy, although not the same as clear cell for sure.
It'll be interesting as that research kind of further evolves, and hopefully as we get more information about chromophobe and understanding the biology of those tumors can be able to help answer some of those questions as well. Does your lab primarily study just clear cell sarcomatoid features, or do you also have samples from chromophobe that you kind of use and explore in your work as well?
We do have some samples from patients with chromophobe and sarcomatoid disease, and we're trying to increase those numbers. So we do, every time that as patients watching out here, you have the opportunity to participate in research. It's so helpful when you do, because these numbers are small, especially for rare tumors. My lab mostly studies clear cell sarcomatoid just because it's so much more prevalent and easy to study. We also have some of our preclinical models, so meaning like cells that we can study in dishes, and mouse models and things are largely developed based on clear cell. But like I said, we're very interested in understanding the differences in chromophobe as well. And like I said, we've done some very preliminary work kind of looking at chromophobe changes. And they do seem to be similar in ways, but also very different. And so I think being able to tease that out better will be really important in not only treating patients and understanding chromophobe disease better, but it'll help us understand kidney cancer as a whole a lot better.
Yeah, that's one thing that I've found the most interesting as I've learned more about kidney cancer in general is just how different chromophobe can be, not only in its response to treatment, but in how it grows and behaves as well too. And so always appreciate labs like yours and those that are exploring kind of the biological mechanisms that are causing those responses so that hopefully one day we'll be able to target those with more targeted kind of treatments for patients down the line.
Yes, definitely. I think what you highlighted there is that's the importance is we really have to understand the biology that's going on behind these tumors in order to treat them better.
Yeah. So, if you were to think about one thing that makes you the most hopeful for patients that are affected with tumors that have sarcomatoid features, or about the understanding of the biology of those tumors, what would you say kind of makes you the most hopeful about kind of the future prospects for those tumors and treatments?
I have a lot of hope, honestly, for sarcomatoid disease. I think there's a few reasons. One is that we know just enough to really be able to study this well. So sarcomatoid is, we know that it's occurring through EMT. We know some of the triggers of EMT, and we have a very clear way to see this. We can truly actually see the sarcomatoid changes histologically. That means we can now understand what properties are different, what genes are different, what proteins are different. And that gives us a really nice roadmap to study this disease. There's other diseases where you don't have that. You don't have like a comparison like that to study. And the other thing I will say is, historically, there hasn't been a lot of great molecular data on sarcomatoid disease. Largely, that's because it's been very hard to study. So, we don't know that a tumor has sarcomatoid until it's looked at under the microscope. And in order to look at it under the microscope, the slide has to be fixed, which means the cells are basically like killed and frozen so that they can be stained. And once those cells are frozen like that, you can't study them in a lot of the ways that we depend on for these molecular studies or used to be limited by. So there's newer technologies, and this is something that my lab uses a lot, is these spatial technologies. So these are things where we can take a fixed slide now, so slides that are frozen, like I said, that we didn't used to be able to study, and we can now look at what proteins are being expressed, what mRNA is being expressed within each individual cell. And so we can see what are the chromophobe cells versus the sarcomatoid cells expressing, and then we can infer, how are they interacting? How are they interacting with immune cells nearby? And this gives us a really powerful way to study these tumors that we just didn't have before. And these technologies have come out just in the last, not even decade, and they're becoming more and more available. And so I think as we use these more, we're going to have very powerful tools to study this disease. I really feel like we're very close to finding out exactly how sarcomatoid is working. And once we know how it's working, we can develop the therapy. So if you think about immune checkpoint inhibitors, those weren't developed for kidney cancer, but we applied them to kidney cancer and they happen to work, very well, actually, but still not perfect. And so if we can develop therapies that are specifically developed for kidney cancer, for chromophobe, sarcomatoid disease, for example, specifically, then those have a much higher rate, I think, or a higher chance of working very well.
Yeah, that's exciting. That I know for me, as I was diagnosed about 4.5 years ago, and that was kind of when immunotherapies were kind of really starting to pick up a lot of steam for patients being prescribed them. And I know there were a lot of patients that I personally knew that were had sarcomatoid features, and being able to see a tumor that was very aggressive, that didn't really have a lot of response to treatment, and I know those patients, I know some of them now that are currently still doing really well based on that. And so it makes me really hopeful to hear you talk about being able to target that biology and figure out the same mechanisms that we can apply to maybe a chromophobe with sarcomatoid features, or being able to find out how do we get more people to have those kinds of responses. Because I feel like I don't know if you've seen very many patients that have had those kinds of responses, but I can imagine that it's probably got to be exciting as you move through your career and be able to see patients do much better in some scenarios with something that was very aggressive.
I mean, it's truly amazing if you think, and if you look back in the literature, if you look at, overall survival for patients with sarcomatoid, you'll find older data that says, anywhere from like 3 to 12 months. It's very, very poor. But now with immunotherapy, when you look at these trials, we're seeing survival rates of many, many years and, even complete responses, meaning some of these tumors are completely responding, having metastatic disease that goes away. So it's really incredible, and that's just in a fairly short time frame. And that's also with just applying a therapy that wasn't even, targeted for this cancer. Like we didn't even know it would work. It just happened to. So now if we can find therapies that we know the biology and we're specifically creating this therapy for these tumors, I think, the potential to even cure these tumors is much, much higher. And I think a really, really exciting for patients and a reason to have a lot of hope.
Yeah, I'm really hopeful and excited to watch as things progress. I think that kind of wraps up the main questions that I had for you for the interview process, but I now wanted to open it up to the audience to see if anybody has any questions. Feel free to drop it into the chat, and then we'll keep an eye on those as they come through. So if anybody has any questions, feel free to surface those. And in case I miss any, I've got Lindsay on the line with us as well too, and she'll make sure that if we miss any in the session, we'll follow up with any questions afterwards as well. I actually had a question for you when we were talking about the tumors that you have samples from already, as well as how sarcomatoid with chromophobe kidney cancer is kind of rare of rare. And so it's really difficult to get those kinds of samples. And you briefly mentioned that it's helpful for patients to be able to participate in research. I was wondering if you could share a little bit more about that, about how patients participate in research, if there's anything that they can help with in that process, and kind of maybe help explain to those who may not have heard of it before how those samples kind of get to your lab
Mhm.
in order to be able to study them.
So one thing that I do with and we do with it with my lab is every time or most of the time that I have a patient that's going to the operating room, I will, just reach out to them and ask them if they want to consent for our study, which what we do is, so like I said, in these large tumors, the pathologists only look at areas. And what, was surprising to me when I learned this, and probably to a lot of you, is the rest of the tumor just gets thrown away. So, it just literally gets thrown away. And so what we ask patients is if we can take a piece of that tumor that would get thrown away and study it in the lab. And so this is how we've gotten some specimens that have chromophobe and sarcomatoid disease that we can now look at and do molecular studies on. So when patients agree to, that really helps. And, it's very, I think it just shows the kidney cancer community, like the studies we do may or may not, but likely will not benefit that patient directly. But they're willing to participate for, patients in the future. And I think that's huge. And I will also just say for patients that have, these kind of rare diseases and there's not a clear answer of what's best to do, oftentimes a clinical trial not only gives you access to therapy that you may not have access to, but it also gives us the ability to potentially answer in the future some of these questions, so that the participating in clinical trials, if it fits for you, is also a great way to be able to contribute.
Yeah, I think that's really helpful context. I know before when I was diagnosed, and even as I was going through surgery, as I was learning about the process for my own tumor, I knew mine was going to be used for research because I had my surgery done at the NIH, for example. So I knew that they were going to store the tumor. But as part of that process was when I learned that so much of the tumor is actually just usually discarded if you don't consent to participate in research, which was something that I never knew. And I knew as a patient, even if I knew it wasn't going to help me, I knew I wanted to help somebody else rather than it kind of going into the trash. And so I think that's really helpful, I think, for patients to know. Obviously, it's up to every patient if they want to participate in research or not, but it can be a really great way to be able to help move research forward. I'll also just mention to anybody listening that we do have ways for patients to donate tumors from kind of any community hospital in the United States to a lab or institution studying it. This goes through pattern.org right now through the Rare Cancer Research Foundation. So any patients who are having an upcoming surgery, you can reach out and we can help put you in contact with those systems to be able to donate samples as well too. And we are working on a biobank to be able to allow patients to be able to biobank their own samples, to be able to send it to labs such as yours as well too. So I appreciate that context because I think it'd be really helpful for patients to know.
That's such a great, I didn't even know about that either. Such a great way to do this too, because, I happen to be studying this at UVA, but if you're at a different institution, there might not be someone studying this. So you might ask like, can I, sign up for a study and they might not have anything, but, so that's an awesome organization. I'm so excited to hear about that.
Yeah, we'll follow up offline too as well, and I
Yes,
can help put you in
definitely.
contact because we currently the samples go to MD Anderson for chromophobe samples, but we are working with other labs to try to set up the process to distribute those to other labs as well too.
That is such a great thing.
So one of the other questions that popped up in here was a question about drug screening, and that cause MX doesn't include FLCN, which are often large and aggressive tumors seen in BHD patients. And so the question was if those patients are less likely to have chromophobe or sarcomatoid features or not. If you happen to know, I know it's kind of a subset of a subset again, but curious if you've
Yeah, so then we're
seen.
getting even more rare. So Birt-Hogg-Dubé is a hereditary syndrome where patients can develop chromophobe tumors, and folliculin is a gene that's associated with this. So the CosMx is a technology that we used in our studies, and so this is a single cell spatial technology. At the time we used it, there was only 1,000 genes available that you could look at. And so what this is doing is it's looking at those genes at the mRNA level in each cell, but there's only 1,000 of them. And folliculin, I believe, was not one of them. So we don't have that data now. I will say CosMx, it's very exciting. Just recently, they introduced a full transcriptome panel so you can actually look at every single gene. And we're planning on doing some really cool studies very soon with that. So maybe we'll find some answers to that. But I think right now, it's just Birt-Hogg-Dubé specifically is so rare, and sarcomatoid disease within that is going to be even more rare. So I don't think we have the numbers or the data that I'm aware of to say whether it's less or more likely to have sarcomatoid features, but it would be, interesting and important to study for sure.
One of the next questions we have here is a question about a very large sarcomatoid tumor, and we can't give specific medical advice here, so we'll kind of abstract this a little bit. And just talking about patients who might have very large tumors, chromophobe can often have large tumors, and I know those with sarcomatoid might have large percentage of sarcomatoid in those tumors. Do you know how patients may best advocate for themselves if they have these large tumors? What's kind of the best process for staying up on their care or advocating? Who are the best contacts for them to kind of reach out to if chromophobe is often rare and their providers may not be familiar with the standard screening processes?
Yeah, I think it's really tough. On one hand, I do always advocate for you do have to trust your providers, your urologic oncologist, your medical oncologist, and their expertise in it. But at the same time, as patients, you also really need to advocate for yourself. And every doctor doesn't know every single thing as well. And oftentimes I've found that the patient knows more about their own disease than I do, because this is your life and you're going to spend every ounce you have studying it. So I think it's really an important balance of the two. And so really bringing up these concerns with your doctor, bringing up the questions, whether it's should I get adjuvant therapy and why? And can you really explain the studies and the numbers and, why you think I should or shouldn't, and really kind of sit down and go through those details can be really helpful. And the other thing I'd say is if you're not sure or something doesn't feel right, always feel free to go get a second opinion as well. Most doctors, myself included, are very open to that. And sometimes it helps. Oftentimes, both the doctors are going to agree and have the same recommendations, but sometimes it can just help to hear it twice and to kind of also see that consensus. So I'd say it's kind of a mix of just really trying to push your doctor to explain the data that's out there that they understand, and then, a mix of being able to put your trust in them, as well as making sure that you are advocating for yourself, because that's, very important.
Yeah, one thing that I learned kind of trying to advocate for myself as somebody who had a rare kidney cancer, I know initially when I was going through appointments, I felt like my physicians would have had all of the information on everything and known every variation that could possibly happen. But later I learned how important it can be if you do have something rare to be able to source some information and bring that information to your physician to have conversations around it with them directly. Have you ever had any patients that have brought you materials and asked you questions about it? And kind of from a physician perspective, what's that dynamic like with your patients? Do you usually appreciate that?
Yes, 100%. It's rare that that happens, but when it does, it's great. Like you said, like a rare type, you're going to find stuff and you're going to know about articles that I don't even know of, because they maybe, aren't in the mainstream of like what I see. And if you think about, the kind of diseases we're treating, there's so much data all the time. We're experts in a lot of stuff, but we can't, know every single paper that was published. So I have had patients that will bring data like that, and it's great to sit down together and look through it, or I'll go home and look through it and then get back to them, and I can actually, sort out the data and maybe have different understanding than they do, and then we can come back and kind of discuss together. I think that's great, and I strongly recommend that patients do that, and I think it's incredible that you did, and patients that are so active in advocating and studying their own disease is how we're going to move this field forward. So
Yeah, and we're starting to collect more and more resources for patients with chromophobe kidney cancer. So anyone with chromophobe, feel free to visit COA's website, coakidney.org, where you might be able to find some of those resources to be able to have some of those conversations as well too, to be able to consolidate a little bit from searching across the internet to be able to find those resources. And this video here will be a helpful resource to patients as well too. So one of the other questions that I saw come up in the chat is about adjuvant immunotherapy. I know that has become approved in clear cell kidney cancer. Can you speak a little bit to if this is something that is being applied to chromophobe kidney cancer and the study population that it was approved in for adjuvant immunotherapy, which is after you've removed the tumor and before you have signs of it coming back?
yeah, so those studies were done mostly in clear cell tumors. And so the approval is for clear cell kidney cancer. Like we kind of briefly touched on, some of the other subtypes, chromophobe included, don't tend to respond as well to immunotherapy. But that being said, not every drug can only be used as it's indicated on label. There are off-label uses, and then there's clinical trials. So if you're someone that, for example, has chromophobe kidney cancer, very aggressive, and interested in adjuvant therapy, I would really talk closely with, your urologic oncologist, your medical oncologist, and see whether there's, any opportunity or any clinical trials that might be good, or, whether they think it would be something that would benefit you or not. But I do know that typically we're reserving adjuvant therapy or the pembrolizumab for clear cell.
Yeah, I think that can be really helpful context and kind of what we talked about of bringing information to your physician to be able to kind of help that shared decision making, just since Chromophobe doesn't respond as well to immunotherapy in some settings, and so it can be really patient specific and helpful for them to discuss with their physicians. Let's see. There's a question here for, does sarcomatoid only appear in larger tumors, or can it appear in the smaller ones as well?
It can appear in smaller ones. Typically what we see is a large tumor. You can almost sometimes like predict, not technically, but you can sort of predict whether a patient might have sarcomatoid or not just based on what their CT scan looks like. You'll often most commonly see very large tumors, areas of necrosis on the scan. You'll see a bunch of big blood vessels feeding the tumor, and then patient may or may not have metastatic disease. But at the same time, I have seen tumors that are pretty small that have sarcomatoid disease. I've even seen very small tumors, like we're talking like 3 centimeters. So it can happen. And why it happens in those small tumors rarely is very interesting and something that we've thought about studying. Are there differences in small tumors that develop sarcomatoid versus the majority of tumors that don't at that size? I don't think we know enough, but it can certainly be present in any size. It's just more common in large tumors.
We had another question here about genetic testing. Is there anything in particular patients might look for in genetic testing? Is it more common for certain mutations for those that have sarcomatoid features when it comes to genetic testing, or are the mutations kind of the typical ones that you mentioned kind of earlier?
There are certain mutations that are more common in sarcomatoid. It may or may not show up in your genetic testing, though, depending on what kind of genetic testing you do. So typically, when we think of genetic testing in kidney cancer, it may be like if you have multiple family members with kidney cancer, or you've had kidney cancer yourself at a young age, or bilateral tumors, that kind of thing. And typically we're looking at germline testing, which means basically looking at like your blood and kind of what mutations do you have in your whole body. Those likely will not show the same thing. So in tumors, it's more likely going to be somatic mutations that you can only see in the tumor. And so often you won't have genetic testing to show that. But there are certain genes that are more associated, like we mentioned, TP53, BAP1, CDKN2A, FN2. There's certain genes that are certainly more common in tumors with sarcomatoid. But again, I wouldn't rely on a genetic test to tell you that. And to be honest, it specifically when you're thinking about sarcomatoid, knowing what gene is involved most likely at this stage and what we know won't impact treatment, at least right now.
Yeah, that's really helpful. I know it was a concept that I didn't fully understand when I was initially diagnosed too. I know I was sent for all kinds of testing, and you just hear as a patient, they're looking for mutations. So understanding the differences between a mutation in the actual tumor cells versus a mutation in your blood that's kind of hereditary might be two different mechanisms at play. And I know the ones we chatted about here were much more research oriented, and that's currently more for developing the understanding of the biology so that one day you can target those, but that currently there's not great targets for those kinds of mutations that are found currently. Is that correct?
Exactly.
Yeah, that's very helpful. I know there's another question that rolled in here to ask what size of tumor is considered large?
So that I guess would be just very subjective. I'd say in general, when we look at staging, larger than 10 centimeters leads to a higher stage. But honestly, when I think just sort of very objectively about what is a large tumor, I'd say anything above like 6, 7 centimeters that's where you're more likely to see some of those aggressive features. But again, it can occur in smaller tumors, and there's really no cutoff, unfortunately.
I know we had another question that came in here about how to arrange pre-surgery to donate a tumor for study. I will post the details about the pattern.org to donate. Anyone can also just go to pattern.org to be able to find more details about that. There's a enrollment section for chromophobe kidney cancers, but I will also follow up to anybody that joined the live with additional details for that as well too. But that did make me think of another kind of question that we were talking about earlier of asking your institution if you can donate your tumor. Do you know how patients might be able to know if their tumor is going to a lab that studies chromophobes specifically, or if it's just going to more broad research? Basically, if there's a lab that's studying kidney cancer specifically, or are there donation programs that kind of just study the landscape of the tumor as a whole? And is there any way to know the difference between the two?
Yeah, so there are a lot of at a lot of institutions, they'll create biobanks just institution wide where they're collecting all sorts of tumors that can be used in different ways. So often someone down the road, an investigator will look back to the tumor bank and say, you know, I'm trying to study chromophobe sarcomatoid disease, like what specimens do you have? And then they can find those. Or someone might be studying like some process that's similar in chromophobe and other tumors and, you know, even outside of the kidney and might look in that biobank. So a lot of institutions will just have their own biobank. Typically, if it's going to be a lab that's specifically studying kidney cancer, most commonly it'll be through like someone will approach you and ask if you would consent to this study, like because they've actually kind of targeted you or found you. So for example, I do kidney cancer surgery, so I ask the patients with kidney cancer. So typically that is how you would get involved in specific studies or through something like you're talking about pattern.org where you can actually seek out those studies yourself.
Yeah, that's very helpful and helpful as a patient to know. I think it's good for patients to know since we don't see a lot of the follow-up that comes from research to have a general idea of kind of what research is going to be done or the possibilities. And so I think it can always be beneficial to help patients in the future. I know one question that rolled in here as well too is about the difference between oncology and seeing a urologic oncologist. So I actually think this is a great question since you're a urologic oncologist. Can you help describe when patients might see which and when the handoff typically happens? Or do you ever have patients that you send to oncology before they have any signs of it coming back?
That's a great question. And I think that this gets really confusing for patients. So I'm glad whoever brought that up. So I'm a urologic oncologist. As a urologist, I'm a surgeon. So typically you're going to see me if we're talking about surgery or if it's a tumor that hasn't spread, and urologists are usually the ones that do surveillance. So oftentimes we'll just watch tumors to see if they grow. And if they don't grow, we often don't need to do anything. But so that's usually my area, or any urologic oncologist that you see is going to be the one that's talking to you about surgery. And then if you have surgery, they're often going to be the ones that are watching to make sure nothing comes back. If anything comes back, or if you develop metastatic disease, or if you have really aggressive features on your pathology after your kidney is removed, often I would send you to see a medical oncologist, and that medical oncologist is the person that the doctor that helps you decide on systemic therapy, so drugs that are given throughout the whole body to stop metastasis, like immunotherapy or TKIs. And oftentimes, you know, if my patients develop that kind of disease, they'll see a medical oncologist. I love when I can also see them back at least periodically, so I know how they're doing as well. I think really having that multidisciplinary discussion and that sort of angle is really important. A lot of patients that have metastatic disease, it's still unknown whether it benefits them to have the kidney surgically removed or not. So that's a discussion that really requires both your urologic oncologist and your medical oncologist. But that's kind of the difference, is surgery versus systemic therapy, understanding that it's very intertwined and really it's best when we're all working together.
Yeah, that's very helpful. I know that some patients too might see just a kind of standard urologist instead of a urologic oncologist. Can you explain kind of what the difference is there? And do you ever have any patients that initiate seeing an oncologist, for example, if they might have seen just a urologist and might have really aggressive sarcomatoid features, who usually makes the handoff? Is that something that kind of all urologists know to do, or is that something that the patient can ask for as well?
Yeah, so urologists are trained in kidney surgery. Like just as part of our urology residency, we learn how to do these surgeries and how to manage patients with kidney cancer. But then you can specialize by doing a fellowship in urologic oncology, which is what I've done. Nowadays, that's kind of what a lot of people are moving towards. But that wasn't always the case. So we have a lot of urologists that may not specifically be urologic oncologists, but they can treat kidney cancer as well and do great surgery for kidney cancer. So that is kind of the difference, that they may treat kidney cancer as well as a lot of other benign things. And they should be able to send you to the medical oncologist when it's appropriate as well. And I would say if ever you think that maybe you should see a medical oncologist and you haven't been referred, maybe you think you're a candidate for adjuvant therapy, ask the doctor. If it's a urologist, ask them. And, like I said, advocate for yourself. Maybe they weren't thinking they wouldn't recommend adjuvant therapy, so they didn't send you. But if you want to have the discussion with the medical oncologist, mention it, and most likely they'll send you, and then you can at least have the discussion.
Yeah, I think that's what's can be one of the most confusing parts of being a patient is knowing who to ask what question to. So I
Yes.
think that's really helpful to know kind of what path and who's connected with who to be able to help kind of help answer those questions and help with the progression of care if needed as well too.
Yeah, it can be so confusing. So I'd say just ask everybody and keep asking until you understand. Someone needs to be able to clarify it for you, and someone will if you just keep asking. So
Well, thank you again so much. I think we're at the top of the hour here. So thank you so much for joining us and for answering all these questions. I know that this will be a really helpful resource for patients to be able to refer back to and to understand sarcomatoid features a little bit more. So thank you for joining us.
definitely. Thank you so much. It's my pleasure to be here.
And thank you everybody who posted any questions in the chat. If we missed any, we'll try to follow up afterwards. We'll have a blog post that summarizes what we talked about here. And so we'll try to catch any questions that we missed in the follow-up as well. So thank you all, and I hope you all have a good night.